Very warm welcome to all the viewers. And today on this health chat with Doctor, I have with me Dr. Ramachandran V, who is a urological surgeon and urologist and who works with Apollo Spectra Hospitals in MRC Nagar, Chennai. A very warm welcome to you, Doctor.
Thank you. Thanks for having me here with you.
Yes, and before I begin this session, I want to introduce you to our viewers. And I was going through Doctor's profile, and it is so impressive, so long. Doctor has done so many things. I know that I cannot accommodate all of it, but to keep it very brief, let me tell you that he completed his MBBS and MS from Tamil Nadu Dr. MGR Medical University. He did his MRCS from Royal College of Surgeons of Edinburgh and FRCS again from UK. And he basically treats patients for male hypogonadism, vasectomy, urinary tract infections, men's health, minimally invasive urology, and so on. And to add to that, he has membership in several prestigious associations like the Royal College of Surgeons of Edinburgh, Associations of Surgeons on India, European Association of Urology. He's an honorary member of Endo-Urological Society, Madras Urological Society, and again, the list goes on. And Doctor has also won many prestigious awards. He's made presentations. So truly, Doctor, it's an honor to have you with us today.
Thank you for introduction.
Yes. So, Doctor, as a common man, we all know that urinary system, it basically helps to eliminate the waste from our body and regulate body fluids. So can you tell us what symptoms are classified as lower urinary tract conditions?
Before coming to that, let me tell you what is the role of the bladder. The kidney, obviously, as you said, excretes all the waste which are supposed to come in the urine. The bladder is basically a container, okay, and it is an expandable, collapsible container, okay. So when it expands, it accommodates more urine. When it is full, it empties the urine. That's the perfect role of the bladder. So the expandability of the bladder is the most important thing. That's why we empty our bladder only when the bladder is nearly full. What if it doesn't have a expansion capacity? Even when the small urine comes, the pressure inside it will increase and we'll have the constant urge to go to urine. So God has given the gift of having the bladder with a little like a balloon where it can expand, accommodate more urine without increasing in the pressure. So some of the symptoms which are associated with the lack of expansibility of the bladder. Patient may have many conditions: neurogenic bladder, bladder overflow obstruction, stricture urethra, even UTI, where the bladder cannot accommodate urine beyond a certain capacity. So those symptoms, lower urinary tract symptoms associated with storage of urine or storage lower urinary tract symptoms. There are a group of symptoms which are happening because they are not able to empty the bladder fully or they are not able to void the urine fully. Those symptoms are complex or grouped as voiding lower urinary tract symptoms. So basically, the storage symptoms will be patient can have increased frequency of urination, constant desire, compulsive urge to empty the bladder quite often, may have to get up more than once in the night, and before they could reach the toilet, they can have the sudden urge so that they wet themselves. These symptoms are related to storage of urine in the bladder, and we call it as storage lower urinary tract symptoms. In contrast to that, those symptoms which are associated with the voiding, like hesitancy, that is unsuccessful attempt to initiate the urination at their desire when they reach the toilet, or sometimes poor flow. The flow pattern may be like, instead of having a good stream, bell-shaped curve, they will have a constant, slow stream of urine. Other thing can be incomplete emptying, or they may dribble in the end or after completing the act of urination. All these symptom complex are called as voiding lower urinary tract symptoms. Many conditions can cause this, including benign prostatic hyperplasia, UTI, even sometimes with bladder cancer, patient can have all these symptoms, or neurogenic bladder, stricture urethra. This symptom complex is common. The lower urinary tract symptom complex is common to many conditions, including BPH.
Okay. So actually, a lot of people have these problems, but I think they fail to realize that they have these problems. That's why I first wanted to understand, these symptoms, because people think it's very okay to go to the toilet multiple times, or, not able to start urinating when they want to, and all those things. So how common are these problems? You've dealt with a lot of patients. How common are these problems? Have you seen a trend in a particular age category or gender category, something like that, doctor?
See, if there is any issues with the bladder filling, they will have symptoms. If there is any issues with emptying of urine, emptying of bladder, they will have symptoms. This symptoms is when I talk about BPH alone, I can say almost 60% of the people will have some lower urinary tract symptoms beyond the age of 50-60. Okay. When you talk about women, they don't have prostate, but they still have lower urinary tract symptoms. And it is quite uncommon for them to have complete spectrum of these complex symptoms, but they have more of urgency or urge incontinence or stress urinary incontinence, depending on the condition which you are evaluating. They will have some lower urinary tract symptoms as well, on and off, more commonly as men, but due to different reasons.
Okay, so I think one of the most common one is benign prostatic hyperplasia, as you mentioned, BPH. Can you please explain what is BPH actually, doctor?
See, like we develop gray hair, like we develop baldness beyond certain age, or developing cataract in the eye, developing prostate enlargement is not a disease, it is a condition. As we grow older, because of the male hormone will have a growth effect on the prostate gland. The prostate gland is situated, it is a walnut-shaped organ situated beneath the bladder at the level of the sphincter. So the prostate has to relax for the urine to go. Okay. So when there is an enlargement, it causes a static obstruction because of the chest enlargement, or the stromal component more than the smooth muscle component in the prostate is more. Then what happens is in a BPH, ideally that happens, it will fail to relax completely, so that urine may not empty properly. The prostate enlargement is due to male hormone status. Many people who have more symptoms need not have a very big prostate. Similarly, people with a bigger prostate need not have a lot of lower urinary tract symptoms as well simultaneously. So we have to match their quality of life and offer treatment for BPH.
What causes this prostate to enlarge?
Like I told you, it is due to the tropic effect of the male hormone having on the prostate. There is a balance between estrogen and testosterone. As they grow older, this imbalance will cause the prostatic hyperplasia. Okay. And there will be prostate enlargement because the prostate is beneath the bladder. It produces symptom due to blockage.
Okay. So earlier we discussed about the symptoms of lower urinary tract conditions. So is there any, some specific symptoms to BPH alone that one can identify?
Well, these symptoms are common for many conditions, like I told you before: BPH, prostatitis, urinary tract infection, bladder cancer, stricture urethra, neurogenic bladder, non-neurogenic overactive bladder. So these symptoms are related to emptying if there is an obstruction, or due to the symptoms associated with the storage of urine because of the poor distensibility of the bladder, in which case it can be a neurogenic bladder, etc. See, basically, the bladder has to accommodate urine without any increase in pressure until the voiding command is given by center. Until then, it should be holding urine. In a patient with a neurogenic bladder, it may not happen. So they will have that voiding urge even when the bladder is not completely filled. So the lack of distensibility can happen in the bladder, even also due to BPH and also due to several other conditions. Any intravesical pressure increase will give us the voiding command, and it increases the frequency, it increases the urge, and sometimes urge incontinence as well. So these symptom complex are not specific to BPH, but of course, in a men more than 60 years, in the absence of UTI, examination wise, the prostate is enlarged and doesn't look like malignancy on finger examination through the rectum, because it is in the from the rectum we can feel the prostate. We can assess that. We can do a uroflow test. We can do a PSA to assess what is the degree of the correlation between BPH and the PSA. That is entirely a different topic. And we can do an ultrasound with a post-void residue, how well they are able to empty the bladder. We can identify all these things, and from there we can take on based on the symptom profile of the patient, how to approach the treatment for such condition.
So how is BPH really diagnosed? You mentioned these ways. So is there any specific test or something that one can identify this condition of BPH?
Simple examination subsequent through the rectum to assess the size of the prostate, and after that an ultrasound scan of the kidney, ureter and bladder will invariably scan the size of the prostate. The size of the prostate will be measured in all three dimensions, and they give the approximate volume of the prostate. If there is any specific concern, we will do a uroflow PSA and assess their symptom profile with the symptom questionnaire, and go ahead with the treatment.
Okay.
This
and what are the treatment
for BPH?
Okay. And could you throw some light upon the treatment options that are available for BPH?
Well, it starts from nothing at all reassurance, first of all, when there is a mild symptoms. If their quality of life is okay, they just wanted to get checked because they are getting up once in the night. Those profile of patients, they come early, they all go on the internet, read about stuff. They are worried about prostate cancer, they are worried about so many other things. They come and check, and when we assess their symptom, their quality of life score, those all will be perfect. When you do a uroflow will be also be normal. But of course, the scan would pick up in bold letters, the prostate is enlarged. And those kind of patients, simple reassurance is enough. That is number one. Starting from that spectrum to medication. There are three different groups of medication available for treating the BPH. BPH is due to two components. One is the size of the prostate. One is lack of relaxation of the smooth muscle inside the prostate. We use a particular group of drug, called alpha blocker to relax the prostate so that they can void more and empty the bladder sufficiently. The another medical group is a 5-alpha reductase inhibitor, we call them. That is a dutasteride, finasteride, etc. Those medicines are supposed to shrink and enlarge. Of course, we give that only when the prostate is more than 35-40 grams to prevent the BPH-related complications in future. So that is second group of drug. We use both these in combination when the prostate is bigger. And then there is another specific group of young patients with BPH. We may even also consider something like tadalafil in association with alpha blocker. So this is for the mild to moderate symptoms, those who want to have some treatment. We start them on these medications. Subsequent to that, if they say that these medicines are not helping them, initially it used to help. Now I more or less feel like despite medication, my symptoms are getting worse. Then we would consider the surgical option. In the surgical option, there are several options available. One is resection, ablation, enucleation, robotic or open surgery. In a way, it is also enucleation, and minimally invasive procedure is also available. So depending on the facility and depending on the patient's profile, how big is the prostate, how long it is going to take time to remove the prostate, we will discuss with the patient about the options available for treatment.
So, doctor, if a patient really comes to you at an early stage of identification, you're saying it can be done through medication alone. It need
Yes,
not
just
go to a surgery.
reassurance. Yes, yes,
Okay,
can be done through medication alone. See, the
okay.
thing is,
But
only 10% of the people with the BPH-related symptoms have surgery throughout world. In
mm-hmm.
India, exclusively, what happens is when they get up 3-4 times in the night, they ask the
Right,
neighbors, and
right,
neighbors say, "Okay, I'm also getting old. I have diabetes, and I used
right,
to get up 3-4 times in the night, so it is not a big issue." So when they come and seek advice from us, it is already at a stage where, technically speaking, BPH surgery is recommended to those people who are going to or likely to have or already having prostate BPH related complication. For example, recurrent urinary tract infection, development of
mm-hmm.
urinary retention, renal impairment, development of secondary to obstructions like bladder calculi, upper tract dilatation, raising creatinine because of the large residual volume, and failed medical therapy. These are all absolute indication for considering more than medication. And depending on the patient's profile, we may choose some procedure. Standard one is a transurethral resection of the prostate. There are several modifications to that. When the prostate size is big, we may consider doing it in saline. We may consider doing laser enucleation of the prostate, laser ablation of the prostate. We may even consider bipolar enucleation. Depending on, we have several options to remove the prostate. It is only the
Right,
prostate is like, there is an inner gland and outer gland. Inner gland is the
yeah.
one which will be enlarged in the BPH patient. The inner gland is close to the urinary pipe. So when it enlarges, it squeezes the pipe, thereby producing blockage. So coming
So,
back to your
doctor,
question, can be managed in different medical surgical options.
so I think when a normal person sees that undergoes has any of the following symptoms that you said, it is always better to come and seek treatment first before the condition worsens.
Yes, yes,
Right. You
obviously.
also you also spoke about different ways of surgery. Now, the same names sound very complicated and scary, doctor. So, as a person, I want to understand the process of the surgery. How long will the patient have to stay at the hospital? What are the anything they need to do prior to the surgery or during the surgery, post surgery, and anything that needs to be taken care of? Because, like I said, the names are always sounding very scary for a common man. They think these are
Okay.
very big procedures.
Okay.
So, a little bit about the procedure and the time taken, the time to recover, and all about that.
Okay. See, basically, when I'm talking about the procedure, it is only most often the conventional standard, the gold standard procedure, against which all other modern method of procedures have been compared with and found similar result, which is TUR, transurethral resection of the prostate, normal monopolar TUR. Okay. When the patient is being seen in the clinic, we talk about them, what is the indication for the procedure, why we are doing that, what is the benefit of the procedure to relieve the obstruction and make their symptoms better. Okay. We also discuss
Okay.
about the potential, the complications associated with the procedure, starting from bleeding, infection, etc., which happens with any procedure for that matter. But when
Right.
the complications are less than 5%, we mention them and reassure them, don't worry, we are supposed to discuss all these problems which can happen so that you anticipate it, and we also anticipate and take a preventive tool. For example, if there is a bleeding tendency for the patient, then we may have to go for laser enucleation. Then I would be consenting for laser enucleation surgery for him. So let me just focus on standard TURP procedure. So after discussing all these things, we'll get the consent from him. I will tell him the anesthetist will have a check with you completely, including a cardiac check, your fitness, everything will be assessed pre-operatively, and then you will get electively admitted. On the day of surgery, you will be kept fasted to facilitate anesthesia, and then you will be put to sleep. The standard methodology of making the patient to put to sleep here in India for prostate procedure is spinal anesthetic procedure, unless otherwise there is some specific issue which prohibits usage of spinal anesthesia. So I would have explained all these things to the patient. And once the
Okay.
patient is put in the position, we will do the surgery. After the surgery, he will wake up with the catheter, and there will be a bag of saline connected to the catheter, which is supposed to clear, because it is a resection technique. There is no open cutting and closure, where there is no possibility of bleeding from internal tissue. What this
Okay.
surgery involves is cutting the prostate. It is like an abrasion wound, like what you have when you hurt yourself in the hand. So the healing process is going to be exactly the same as an abrasion wound, which you get by any injury for that matter. Initially, there will be a red scab form. Subsequent to that, a blackened area will form over there, and then the external blackened area will shrivel and peel out so that the new white screen is developed. Until then, patient can have some symptoms. I also explained that to the patient post-operatively
Okay.
what to do for. So the irrigation is given for 24 to 48 hours to limit the bleeding, because it is like an abrasion wound where you dress the wound. Here, the method of dressing for an internal wound which we created by surgery is by giving irrigation, so that even a small trickle of blood which is going to come is not going to produce a clot and block his urinary tube. So irrigation will be there for 24 to 48 hours. Once he resumes normal diet, moving around, and once he passes motion, we'll remove the catheter and we'll ensure that he is emptying his bladder fully, and then that will be the time to get him home. Approximately, it will take 3 to 4 days after surgery for a patient to go home with the conventional procedure.
So after that, do they need to come back for follow-up, or it is done and then they heal and they are back to normal life?
See, ideally, what we do is we see them once with the biopsy report.
Okay.
Whatever we remove, we send it for histopathology for biopsy. Obviously, if we are expecting BPH, we are expecting BPH only. Some patient can have some micro abscess. Incidentally, some patient can also have less than 1 or 2% of patients may have prostate malignancy also in such sample. So we have to review them once with the biopsy. And after that, we will be seeing once again at about 3 months' time. There is no problem. They have reported to me in the first appointment.
Okay.
Subsequent to that, only when there is a new symptom or if they have any particular problem, then we'll ask them to come. Subsequent to that, there is no need for follow-up.
Any kind of risks that are associated with these surgeries? Something to be taken care of?
Well, the risk is the complications which we expect in such surgeries, which we would have already discussed with the patient at the time of discussing about the operation options. Another risk is bleeding. That's about 1 to 2%. Another risk is infection. That's about 1 to 2%. Another risk is incontinence, stress urinary incontinence, because you'll be cutting on the internal sphincter. But obviously, the external sphincter will be preserved in a good technique. But some patients with the long-standing obstruction, the bladder develop extra muscle thickness. Okay. Because then only it's like doing physical exercise, muscle training. When you want to develop a six-pack, you have to work against the resistance to develop that. So when there is an obstruction, the bladder muscle will go for thickening so that it has more capability to contract and empty the urine. So what happens once you remove the prostate, the bladder muscle will still assume that I have to keep working harder like before. But what happens is the obstruction is relieved. They need not work harder. For them to get, for the bladder to get tuned to the new unblocked environment, it will take time. So they may have urgency and urge-related incontinence, sometimes very rare, which we also mentioned, less than 1%, but even stress urinary incontinence due to sphincter damage, which can happen in a prostate which is extending up to the sphincter beyond a particular landmark which we used to call as Peru. When it extends beyond that, it happens in a very huge prostate. When you are heroic and try to remove the complete prostate by TURP, there is a slight chance that some of the sphincter fibers can get included, and when it gets included, they may have stress urinary incontinence. Although it is less than 1%, we still tell them. develop because it is
So,
yeah.
no, so
Yeah,
patients who undergo the surgery, they are the success rate is very high. They are not facing any issues after that. Because earlier you mentioned uh, people who are on medication first, beyond a point, sometimes they feel medication is not working and they have to move to surgery. But
yes,
surgery, is it like the final solution? The success rates are very high in your years of service. How do you see that, doctor?
99.5% success for if there is a genuine prostatic obstruction is the reason for that problem. 99.5% success. The
That's a
remaining
wonderful
some
number.
of the
Yeah.
yes, yes, but it has to be a juicy, definitely obstructive prostate. If you do urodynamic study, you find bladder outflow obstruction, you do the surgery, 99.5% success.
That's
Sometimes what
great.
happens is patient may have a gray zone prostate, patient may have a gray zone weak uroflow, but lower urinary tract symptoms could be significant. The only way to improve their symptoms may be to do a small resection. They may have elevated bladder neck, so a small resection is itself is enough. When you do for such indication, the outcome may be poor. Similarly,
Okay.
when the bladder is decompensated, and then because of the long-standing obstruction, when you do TURP, obviously you have to relieve the obstruction. When you do TURP, the success is going to be little less. And similarly, when they develop secondary complication like acute urinary retention, see, by the way, urinary retention happens because they could not generate enough power to pump against the blockage. That means once the bladder gets over distended, it loses the muscle strength. Then
Right.
it is not able to empty the bladder fully. Initially, we put the catheter, we give them trial voiding. If they are successful, we tell them there is a 70% chance that in future you will develop recurrent retention. You better get surgery done. When we do surgery for symptoms, lower urinary tract symptoms, the initial question you asked, alone, the
Yes.
success is higher. And they develop complications like acute urinary retention, and the retention volume is more than, especially when the retention is painless, without any pain. Patient will come with a bloated lower tummy, and they will have a large 1500 ml urine staying in the bladder. When you do surgery for them, because the bladder is not having enough power to pump the urine, despite it might have happened because of the blockage, the outcome of surgery is 60-70%.
Okay.
However, if you keep them on catheter, train their bladder regain some tone, give them some bladder, procholinergic medication, and ultimately the success would come to 80% in long term. But people may not able to accept the catheter after surgery.
Right.
The very
So
idea of
earlier,
treatment surgery. Yeah.
earlier you had mentioned that after the surgery you send it for biopsy. Have you seen any link between BHP and prostate cancer? Because that's another fear which people generally have. So,
See, the BPH predominantly happens from the central zone of the prostate. We call it as transitional zone. That is the zone around the water pipe. From the bladder, there is a urinary pipe. Around the pipe, beneath the bladder, the central zone of the prostate, where the BPH happens. The peripheral zone, that is the posterior zone, the one which you examine with your finger at rectum, is from where the prostate malignancy happens. Very rarely, say 5 to 6% of people may have exclusive central zone, that is the transition zone prostate cancer. So when you do TURP, sometimes you can have a surprise, like they may have some malignancy in the prostate in the transitional zone also. So it is
okay.
compulsory, necessary that when you do circumcision, you need not send the specimen always for finding any problem, pathology in it, unless otherwise you have something in mind. But in the prostate, it is not the same. You have to send it for biopsy to find out what is the problem. Supposing there is a chronic prostatitis, we may have to keep them on alpha blocker as well for a long time. Patient commonly asks them, doctor, do I have to use medicine after surgery? Commonly we say no. Once the surgery is done, you don't have to use medicine. But if you find some prostatitis, alpha blocker is a recommended treatment for prostatitis. So that biopsy report is key for me to determine in future if they have lower urinary tract symptoms, say in about 3-4 years time. This biopsy would help me to treat any symptoms residual after that.
Okay. So, doctor, one final question. From what I understand, the enlargement of prostate is very common among men, especially after a certain age category. So, do you recommend any kind of screening, or should they voluntarily come for treatment? And in today's age, I have to ask also about the lifestyle changes. Can it be prevented? I mean, can PH be prevented? Any lifestyle changes that you would recommend for people to be more healthier and maybe push this to a later time?
Let me take this one by one.
Right.
Is there any way that they can pick up their symptom early? Yes. Lower urinary tract symptoms, I've been mentioning. If any patient have to void in between 2 hours in the daytime, I mean less than 2 hours per cycle in the daytime, or if they have to get up more than once with the intention to pass urine, or if they feel like they get urge to pass urine, or if they feel they find it difficult to initiate the act of urination, or if they feel like the flow strength used to be good, now it is not that great, or they feel like, doctor, I'm passing urine, but I'm still not happy that I emptied my bladder fully. If these group of symptoms anybody is having beyond the age of 50-55, it is better for them to get their prostate checked. When they seek help from us, what normally we do is we examine the patient, we ask their symptoms, we ask them how these symptoms are affecting their quality of life. For example, at 70, even getting up 3 times in the night may not be a problem for a retired person. Supposing if he is still working, say 50-55, and he has to get up 3-4 times in the night, and he has to go to work in the morning with the sleepless nights, he is going to seek help more than a 70-year-old who is getting up 3 times in the night. In fact, the 3 times in the night may be a bigger issue. See, what happens is aging, the bladder muscle also will lose its strength. Okay, so it is a dynamic relationship between the bladder contraction and the sphincter relaxation to help in emptying of urine is the core issue here. Does it affect his quality of life? Primary question. If it's so, then he will require treatment. If it can be picked up by these symptoms, yes, they need to seek help from us. We will do examination, ask their symptom question, do some battery of investigations, and tell them what is the problem. It is not a big thing, like we develop gray hair and baldness beyond certain age, like women developing sagging breast after menopause. So it is an aging process. If we explain to them it is not a big disease, it is just a condition, but we don't allow them to mature into a problem which can be due to complications of incomplete emptying, like recurrent UTI, we can use some predictive tool using PSA, Euroflow, age, prostate size, etc., and determine which kind of prostate is going to get progressively worse, which is going to be static. For example, some 80-year-old gentleman comes to me with a 35-gram prostate. By textbook standard, 35-gram prostate would require a combination therapy. That means it is a BPH. Would you be interested in operating on them? Of course, if his symptoms are worse, we may give them the option. But whether that surgery on 85 with a 35-gram prostate is going to help them to stay symptom-free is a big question. Okay, so it depends on the kind of the patient, what is their expectation, how well is the quality of life is on par with the their peers, and how well it has worsened. All these things would determine what kind of action or to what level we will aim at the treatment and provide them. So it can be early detected, provided patients are aware about the symptom, they seek medical help, and we examine, we assess their quality of life, they tell us about their quality of life also. We do some batteries of investigation. and then we will categorize them as mild, moderate, and severe, and as small prostate, moderate prostate, huge prostate, etc. We give them option, and when we give surgical option, it can be a wide spectrum depending on what kind of problem profile we are going to face with that particular patient. So the choices are plenty. Only thing is we need to rationalize that and advise the patient according to the situation.
Well, thank you, doctor. I know I took a little much of your time, but
No,
for all of our viewers, I'm sure they have a lot of clarity on what exactly they need to do, what to look out for in terms of symptoms, when to seek treatment, and more importantly, I think the peace of mind that an early treatment can help them lead a normal life. And if they have to even move to surgery, you said that the success rates are very high.
quite
So.
quite
Yeah, so they can dream of leading a normal life even in case they have an issue. So thank you so much, doctor.
Thank you.
It was a
Thank you
pleasure
for having me.
speaking to you. Yes, and to all our viewers, I'm sure this was a very informative session. I hope you all enjoyed it. So till we meet again, everyone stay healthy and stay active.
Thank you.
Bye-bye.
Thanks for the time.
Yeah.